Hello, everyone. This is Dr. Madhusudan Rao, and the program I teach medical students. Today in my class, I'm going to touch briefly on the topic normal pressure hydrocephalus. Normal pressure hydrocephalus is a reversible cause of dementia in the elderly. It was first described by one Colombian neurosurgeon, Hawkins and Adams, in 1964. It was described as a trade of disturbed gait, dementia, and the urinary incontinence. Let us talk about this, about its definition, etiology, and the clinical manifestations and treatment profile. Normal pressure hydrocephalus is potentially reversible cause of dementia, which I told you. It's common in elderly persons. It was initially described by Colombian neurologist Salman Hakim and R.D. Adams in 1964. It was described as a type of progressive gait disturbance, cognitive deficiency, and urinary incontinence. It is said to be the most common cause of hydrocephalus in adults. Initially, there was a controversy regarding the terminology, as CSF pressure is not normal in most of the cases. Some of the cases rather is. So the term idiopathic adult hydrocephalus syndrome is used. The current term is idiopathic adult hydrocephalus syndrome. So let us see about it. Coming to epidemiology, male and females are equally affected. Okay. The average age of onset is around 70 years. About 0.2% in the age group between 65 to 79. At the age of 80 and above, nearly 5.6% of people are affected. Coming to the definition. As defined by the International Society of Hydrocephalus and Cerebrospinal Fluid Disorders guidelines, normal pressure hydrocephalus is probable when the patient was 40 and above, presents with progressive gait disturbance for more than 3 to 6 months in the absence of comorbidities, which could fully explain the symptoms. So this is the definition given by International Society of Hydrocephalus and Cerebrospinal Fluid Disorders guidelines. Okay. That means when a patient around 40 years presents with progressive gait disturbance, okay, lasting for more than 3 to 6 months, and he does not show any evidence of comorbidities that could fully explain the symptoms. So in that scenario, the diagnosis of normal pressure hydrocephalus is most probable. Okay, let us see what it is. Coming to etiology, there are two types of NPH. One is idiopathic, where the cause is not found. And secondly is associated with previous history of infections, say the meningitis. And it could be past history of trauma to the brain, that is traumatic brain injury, as you call it, as TBI, or intracranial hemorrhage. So these are the secondary causes or causes of IPH. That means INPH. Okay. INPH does not have any cause, but it is otherwise secondary or SNPH. You call it as it is. Secondary normal pressure hydrocephalus is abbreviated as SMPH. Okay. This secondary normal pressure hydrocephalus usually responds to shunt surgery. Or if they treat the primary cause, the prognosis is good. They are present in the elderly age. Whereas idiopathic cause is not known, more common in elderly persons. Okay, and is rather less responsive to the treatment. With regard to the clinical presentation, both the types they are common in clinical presentation. They are present with progressive gait disturbance, dementia, and urinary incontinence. Those who present with gait disturbance as an early manifestation, they do better. If elderly person present with a remarkable dementia, the prognosis is poor. Well, in both the varieties, type of hydrocephalus is communicative hydrocephalus. And the CSF blood pressure in both the conditions is normal. With regard to the prognostic criteria, prognosis is rather better in the secondary type of normal pressure hydrocephalus. Okay. If they undergo early surgery, the prognosis is better. Even early intervention is going to prevent the patient progressing to dementia. Okay. So that's why the early presentation will be the gait disturbance. And if the patient undergoes surgical intervention at that particular stage, progression to dementia is unlikely. And these two types differ in age of onset. Idiopathic type, they present in older age group, whereas secondary non-NPH, their patients are usually young. They may present at any age, but usually common in younger age group. What is the pathophysiology? Pathophysiology rather not fully understood. Okay. Certain mechanisms have been explained, which include because of the dilatation of the ventricular system, which is associated with this particular syndrome, there is increased lateral pressure on the periventricular white matter. Okay. And there is sort of traction injury to the white matter. And also there is reduced perfusion and ischemic trauma to the nerve fibers. Okay. The periventricular area, the white matter includes the nerve fibers that supply the lower extremities. And there is compression on these structures, there is reduced perfusion and ischemic injury, as well as the traction injury to these fibers. Because these fibers innervate the lower extremities, that is the lower limbs, that will produce in gait disturbance. Okay. And hypertonicity and hyperreflexia of the lower extremities. The same is response for early symptoms of urinary incontinence. Okay, bladder dysfunction becomes disturbed, and bladder becomes dysfunctional in the early stages, secondary to the traction injury to these particular nerve fibers. Okay, that supply the what I call sacral segment of the spinal column. Okay. And gait disturbances is due to nerves that run in the periventricular white matter. There is also found there is increased resistance to CSF flow in the subcortical or subarachnoid space. And there is impedance to the CSF flow in the subarachnoid space. There is a sort of imbalance in the formation and absorption of cerebrospinal fluid. There is hyperdynamic flow of CSF in the aqueduct. That is one finding that has been said to be the associated with the this normal pressure hydrocephalus. CSF pulse pressure is elevated and blood flow, cerebral blood flow is slow. Okay. And it was also found that cerebrospinal fluid clearance, capacity to clearance certain of the toxic elements is markedly diminished. And there is the inability of the CSF to metabolize some toxic elements like tau proteins, which results in damage to the nerve cells. This is one finding that has been found. Coming to the CSF flow dynamics, you see this particular chart. In normal individuals, CSF is formed at a rate of 0.4 ml per minute, whereas in NPH, it is 0.25 ml per minute. Okay, and again, CSF volume, it is around 150 ml in normal individuals, whereas in NPH, it is 300 ml. So, remarkable, double the volume. That results in the dilatation of the ventricular system. Turnover is only 1.2 ml. There is remarkable stasis of CSF in the circulation, that is, in the ventricular system and the subarachnoid space. That results in the increased pressure, or initially there is increased pressure, followed by there is reduction in the brain mass. Ultimately, it shows normal pressure tracings. Then how does it present to you? The patients present to you normally with gait disturbance. Gait disturbance is the earliest manifestation. Okay. Why it is due to compression or the traction injury of the white matter in the periventricular area. Okay. And also it suffers with reduced blood perfusion and ischemic injury of the fibers that innervate lower extremities. Okay. In the prefrontal and pedunculopontine areas also, there is a ischemic injury to this white matter, thereby resulting in a set of motor manifestation in the lower extremities, and also because the prefrontal is affected, it also affects the motor nerve cells that are there in the premotor cortex. Besides, it induces a sort of cognitive impairment besides motor impairment due to the involvement of the prefrontal motor cortex. Gait disturbance is the first symptom to appear, at the same time first to disappear following shunt surgery. Because this is the earliest manifestation, the early surgical intervention is going to give better outcome. The patient walks with shuffling, freezing, or part-based gait. The shuffling or freezing or broad-based. The limbs or the lower limbs are stiff, frozen, stuck to the ground. The width of the gait, that is, width of the step, as well as the height of the step is also remarkably reduced. Length of the step is reduced, and the height of the foot clearing the ground is reduced, and the stiff or frozen gait, sort of freezing gait is the characteristic feature of and gait in normal pressure hydrocephalus. This is a shuffling or freezing or broad-based. Okay. And the characteristic feature is difficulty to initiate, as if patient's stance is as if frozen. He is unable to lift the foot, lift the leg off the ground, and make the step forward, as if he is frozen, stuck to the ground. This is called freezing gait. There is internal rotation of the feet, poor foot clearance, that is shuffling or festinating, taking multiple steps to rotate. When he is asked to turn around, he takes multiple steps as the foot is stuck to the ground. Coming to the other motor symptoms, there is disequilibrium, he tends to fall and is worsened by closing his eyes. His stance is broad-based, and to maintain the gravity, he stoops forwards. Retropulsion is there, but it improves with shunt surgery. In 40% of the patient, tremor occurs. Tremor does not improve with surgery. That's why a trial of levodopa is advised to exclude Parkinson's disease in these patients. Dementia is characterized by inertia, forgetfulness, inability to perform executive functions. There are a lot of manifestations with regard to dementia. Okay. There is a comprehension is good, but thought generation and response to the questions is slowed down. That is the characteristic feature. That is called inertia. Judgment is normal, but expression is impaired. It is caused by compression injury to cortical layers. Okay, the frontal area against the inner, that is the cranium. It is the cortical layers are pressed against the inner surface of the cranium, and as it is pushed against the skull bones, thereby they suffer from the diminished perfusion and ischemic injury. Coming to the urinary symptoms. Urinary symptoms are primarily due to detrusal muscle dysfunction. The presence has urgency and incontinence. Well, early symptoms are due to, as I told you, as traction injury to the periventricular white matter. Okay, these fibers innervate the spinal sacral segments, which ultimately innervate the detrusal muscle. Detrusal muscle dysfunction is secondary to the injury to the innervation of the muscle. Later, dementia contributes to the urinary symptoms. Well, I show some of the pictures of NPH. This is the patient with normal pressure hydrocephalus. See his stance. He is unable to stand erect. He is bending forward, stooping forward, and is disequilibrium and imbalance. His image, CT image, shows dilated ventricular system. So the ventricular system that is dilated, and there is atrophy of the cerebral atrophy. You can compare the normal person with the normal pressure hydrocephalus. This is the normal individual showing the normal ventricular system. Okay. Normal subarachnoid space. Okay. This is the ventricular system which is normal. So compared to the patient with normal pressure hydrocephalus. You see, in the subarachnoid space, CSF is built up. This is the skull. And this is the ventricular system. You can see the cerebrum or the brain that is compressed, resulting in the ischemic injury to this particular area. This is responsible for all the symptomatology. Say dementia, say the other pieces of more motor manifestations, etc. This slide shows progression of INPH. So asymptomatic stage. At this stage, radiological there is radiological indication. Example, ventricular enlargement is seen in the CT scan. So if you go for the CT scan of the individual before the symptoms are produced, if there is ventricular dilatation, that is the stage of early diagnosis. Then one clinical indicator, say gait disturbance with enlarged ventricular system, possible NPH. Worsening clinical symptoms and two more other core symptoms. Worsening radiological left ventricular dilatation with worsening clinical symptoms, example, two or more other core symptoms. It is definitely probable. So, dictum is the dilatation of the ventricular system. With the dilatation of the ventricular system, if you find at least one clinical symptom, say one or two, one is possible, there is NPH is there, and then one more than one, there are two are there, definitely that is probable. So look at the image, CT image of the brain showing the dilatation of the, it's a rounding of the gantry horn of the lateral ventricles. This is the sign, we call it as the, this is a diagnostic of IPH. Look at this particular picture. This is the normal MRI. This is the MRI, is the normal pressure hydrocephalus. Dilated ventricular system. There is the dilated subarachnoid space around, and there is atrophy of the brain, showing the prominent sulci. And this patient underwent the surgery, that is the shunt surgery, is from the lateral ventricle down to the abdomen, it is draining. It is from the fourth ventricle, it is here, there is a valve-like technique is used to drain the CSF. Well, this slide shows MRI of the brain showing the Evans ratio. Ratio of maximum width of the frontal horns of the lateral ventricles and maximal internal diameter of the skull at the same level. Okay, if the ratio is more or 0.2, 0.3, it defines ventriculomegaly. This is helpful in the diagnosis of NPH. This is the what is looked for when you take the MRI of the patient suspected of NPH, and the patient presents with the early signs of gait disturbance. If you go for the MRI of the brain, the diagnosis is confirmed. Coming to the diagnosis and treatment, CT brain shows some changes, but not that confirmatory. Shows some degree of ventriculomegaly. Definitely, you have to go for MRI at that time. MRI is better option. You can see the Evans angle, which I showed in the previous picture. Subcortical lymphoids also can be delineated. Ventricular size with reference to their structures and white matter changes can be observed in MRI in detail. Well, patients with following features, they'll have an unfavorable outcome. That is, severe dementia with which he presents, and a diffuse cerebral atrophy or unfavorable factors to determine the prognosis. Surgery. Early shunt surgery improves the outcome in most of the patients. And we can also proceed with the CSF drainage diagnostic test, wherein 30 to 50 ml of CSF is drained by spinal tap for 2 to 7 days, okay? And observe for the clinical improvement. And also retest the CSF pressure, okay? And then, or else you can do continuous CSF drain, 150 to 200 ml per day for 2 to 7 days. This particular test has 80 to 100% positive predictive value and 50 to 100% sensitivity. Okay. If the patient shows clinical improvement following CSF tap test, it's a good sign that the patient is going to improve with shunt surgery. Then the patient can proceed with the shunt surgery and the outcome is good. At the same time, the follow-up is very important, at least 2 times in a year for 3 to 5 years continuously. This is all what about the normal pressure hydrocephalus. Thank you for patient listening, my dear students. Hope you could understand the pathophysiology, clinical manifestations, and the importance lies in observing the patient who presents with a gait disturbance at the age of 40 years, around 40 years, okay? Then early diagnostic test in the form of MRI is always advisable. Thank you very much for patient listening. We'll meet you again in the next class. Until then, bye-bye.